Hi, everybody. It's Karen Anderson here with Aortic Hope, and we are so excited to kick off September Aortic Disease Awareness Month. And as you know, we tend to do quite a lot of live events and a variety of activities, and this month will not fall short. So we are going to start this month off with our first live event with Dr. Ben Youdelman. And he is a huge supporter of Aortic Hope and part of Think Aorta, which we support that as well, and also the brains behind Aortic Bridge. So we're going to talk about a little bit of all of that in a little bit, and our format is typically I'm going to have Ben go ahead and share with everybody a little bit of information about himself, and we're going to jump right in with talking about the aorta. And if you have questions, post them below in the comments, and don't forget to like and subscribe. Hey, Ben.
Hey, Karen, thank you so much for having me. I really do appreciate these events, and it's just a pleasure to actually be able to be sitting down for part of the day, which is nice. I appreciate that having the casual dress, and as you guys can see from the posters behind me, these are not staged props. Karen can tell you that they're always in my office, with the exception of last week when it was raining in my office and I had to move them, but now I've moved them back.
Okay.
My Think Aorta display case.
Very good. And at least it's not raining after all of the rain that we both endured over the last 12 hours with
Indeed.
Ida, remnants of Ida. All right. So do you want to tell everybody a little bit about your background?
Yes, indeed. Thank you. So I am a fully trained cardiothoracic surgeon, which means that I did 5 years of general surgery training. I did 3 years of cardiothoracic surgery training to operate in the chest and elsewhere. And then I did an advanced fellowship in thoracic and endovascular aortic surgery. And the purpose of which ultimately was to be able to assume the position that I am in right now. I'm currently the co-director of the Aortic Center at Maimonides Medical Center in Brooklyn, New York. And I am the director of the thoracic aortic surgery program in the group of cardiothoracic surgeons that I work with, which means that when patients come to our hospital or any of the surrounding hospitals and they have an aortic emergency, such as a rupture or dissection, they call me and my team, and then we come in, rain or shine, as you know, and operate on them. Additionally, we have an educational program for both the physicians. We've been trying to do that on a biannual basis, but that's been a little challenging the last few years. But the other thing that Karen had mentioned is our Aortic Bridge group, which is sort of like a little kid brother of the Aortic Hope group. And the Aortic Bridge group is charged with both supporting the patients that we have, and now we're more broad because we've basically joined you guys in bringing our support group, sort of folding it into your group. And really, our group really just exists when we get together, such as our walk, which is coming on in 3 weeks. And obviously, we'd have you guys join us, but it's tough to everybody get to New York, especially now. But in terms of the aortic bridge function, it really has a bunch of arms. One is the patients, and then the other is that we do a lot of outreach for both primary care physicians, emergency physicians, and I do a bunch of talks for the paramedics here in Brooklyn, including the fire department and all the private and public groups of paramedics, in order to explain to them that they need to change some of their approaches to patients with severe chest pain, just to identify the potential for there to be an aortic emergency, and then communicate that to the people that they are bringing the patients to. So we really have a lot of overlap between Aortic Bridge, the very local group, and joining Aortic Hope to a large degree on the patient support side. And then, of course, our work with Think Aorta, which is now an international organization. So I really like the way this all dovetails together, and we all get to work together to try and help patients, help physicians, help healthcare practitioners. And it's really a wonderful, wonderful thing. And it's just a pleasure to work with you, as you know, Karen.
Thank you. Same here. It's one of the things we like to talk about when it's day one of information today, is we started off sharing with the community really what is the aorta, because still, believe it or not, a lot of people people who find out they have an aneurysm or they've had a dissection. I mean, these are the groups of people that come to us. As you know, the catcher's mitt post-diagnosis, they still don't even know what the aorta is. They think it's part of the heart. And so they get lumped into heart disease or heart illness or injury. And so it's not. So if you could explain to everybody, easy terms, really what is the aorta?
So interestingly enough, the aorta is a large blood vessel which comes out of the heart. If you excuse me for a moment, I'll get you a heart.
Now, is that actually the size, diameter-wise, of what it typically is?
This is slightly bigger. If you look at my thumb, most people's aortas are supposed to be the size of their thumb, and we operate on them when they become the size of your fist. This may seem kind of strange, but the easiest way to look at it is if you put your thumb up in the air, that's what it should be. And if you put your four fingers up in the air, that's usually when we operate. And it's a very good rule to explain to people why, when we say it's big, we're not meaning a small increase in size. It's fairly large. So
Right.
we'll start with my favorite plastic structure here, which is my favorite plastic heart. And the heart, of course, is positioned slightly to the left of the chest. The aorta comes out of the left ventricle, goes past the aortic valve, and it then enters into the area above called the aortic arch, which gives off blood vessels to the arms and to your brain. Shifting to my other model, if you will. This now comes up, it gives what's called the head vessel branches, and then it comes down. And in this model, there's an aneurysm or an enlargement of the aorta in the area of the descending thoracic aorta. This then goes down towards the belly, and right around your belly button, it separates into two blood vessels, one going to each leg. Now, of course, there's blood vessels along the way, and not just these really important ones going to your brain and your arms, but the aorta itself is the trunk of the tree, life carrying blood to every single artery of the body. So that's why it has tremendous importance. And if there's any problems with it, that's why it becomes a huge issue.
Okay. So I love that you just showed that as the thoracic descending. That would be a thoracic descending aneurysm. So it's only ascending as it comes up and right when it hits the arch, and then it becomes descending, correct?
Correct. Correct. So as I tell people, this area is the ascending, this is the arch, and this is the descending. It is basically the shape of a cane, and the top of the handle is the arch, and the small part is the ascending, and then the big part is the descending. It's the easy way to think about it, candy cane or otherwise.
Right. So your thoracic stops at about the level of what? Breastbone, rib cage, bottom of the rib cage. When does it deviate to become
Right around that funny little thing at the bottom of your chest, called the xiphoid process with an X. So the bottom of your rib cage in the middle is about where the aorta goes into the belly and then gives off blood vessels that go to your intestines and your kidneys and all those gross things down there.
So you can have this aneurysm, which people can have for so many different reasons. And most of the time they don't know they have an aneurysm. It's usually found on a different, for a different reason. What are the types of tests that typically people, they have that it shows them they have an aneurysm, any place of the aorta?
So classic case is what happened yesterday, where I had a call from one of the cardiologists that I work with who was meeting a new patient who didn't give any history of aortic aneurysm rupture or dissection. And she always asks, and she does a routine echo. And if you look at the aortic valve and the immediate area above the heart on an echocardiogram, you can see an aneurysm. And she saw the aneurysm and she got concerned. She asked the patient if the patient had ever had a CAT scan, and he said that in fact he had had a recent CAT scan. And she referred the patient to me immediately because she was concerned, and of course the patient was concerned. And I had the patient just come sit in my office for about 20 minutes. We went over the studies, and then we set up a follow-up appointment. These are the most common way that people will find that they have aneurysms in 2021. The second fairly common way is that we know it runs in families. And so anyone who has one, we now implore people to have their first degree relatives, meaning their parents, siblings, and children, get evaluated. Parents and siblings at the time of discovery, and the children 10 years prior to when it was discovered, or age 50, whichever is the youngest age.
Okay.
And then a lot of times, people, now that it's becoming known that you have to think about the family, we're now seeing more and more people coming to us with enlarged aortas who come to me with a story about the family having a aneurysm or a dissection or a rupture, and they now are coming to us with a lot more information, which is really fantastic.
Now, you just said a word that anybody who's watching this live or will see this on replay is going to really, light bulb's going to go off. When you said enlarged, people throw around enlarged, dilated, and then aneurysm. What do all of these mean? When is it really considered something? Yeah, we've seen people on Facebook turn around and say, "Oh my goodness, I have an aneurysm. I have my aorta is a 3.8, 3.6," and I sit here and I don't get involved with everything, but I know enough to know that unless that person is like the size of my finger, that's probably not necessarily really large. A lot of factors here, but can you explain that, define that a little bit more?
Sure. So this goes into a very complicated discussion, but I'm going to break it down simple like I do for all of my patients, which is that the average size of human beings that we see are about from 5 feet to 6'5". Sometimes we see a little smaller, very rarely taller. And within this range, we would anticipate that the aorta, being the size of the thumb, would always be less than 4 centimeters. Now, 4 centimeters at 6'5" is not very big. 4 centimeters at 5 feet tall is also not that big. And that's why I feel very comfortable. The issues, as you mentioned, if people are very, very small, and I do have a whole series of patients, because in Brooklyn, we have patients from all over the world. We have a series of patients who the tallest person in the family may pass 5 feet tall, but huge numbers of people who are short. And we have a conversation about how big is big. But in general, since we really do have an average that we can work with, where 90% of the population will fall within that size range, we say that anything larger than 4 centimeters, so 4.1 centimeters or larger, if there's a 4, it's an aneurysm. And
Okay.
the reason that we do that is to simplify it. We can make things more complicated for sure. And sometimes when we're doing scientific analysis of patients, we do. But for the sake of this discussion, if you have a 4, it's an aneurysm.
Okay. Here's the next thing that's thrown out in the community. You go in, you have your scan, they tell you it's a 3.8. You go back a year later, it is a 3.9. I'm going to give you a couple different scenarios we're going to talk about. Is that really growth? If all things are considered, you're in the same machine, same person reading it. Is it really growth in millimeter or is it not?
So I'm going to bring you back to the model here.
Mm-hmm.
If you can picture cutting across this on different planes, you could see very quickly how you could get whatever size you wanted to get in this aneurysm. And the
Mm-hmm.
reason that the aneurysm is measured differently at different times is an extraordinarily complicated combination of, number one, your body position in the scanner and the way the scan is done. Number two, the post-scanning data analysis that is performed by the radiologist, because unless you're one of my patients or one of the people like me who measure their own CAT scans, and most of the aortic surgeons that I work with, we measure our own CAT scans. We abide by the rules of residency, which is trust no one and believe nothing and
Mm-hmm.
do everything yourself, which is really the way we survive in a very complicated business, up until the point where we surrounded ourselves with a team that we really do trust. But in terms of measurements, that is a really nuanced, complicated thing. So going back to that body positioning on the table, how hydrated you are at the time, your blood pressure at the time of the CAT scan, and then the actual technique of measurement. The technique of measurement we're going to take away because everybody does things a little differently. But if you're very, very hypertensive because you're nervous, because you're getting the CAT scan after a year and you're worried and you haven't thought about it, and you go there and you're lying there and you know you're going to go see the surgeon right afterwards, your blood pressure is going to be a little higher. Well, the aorta is actually a capacitor, meaning that it will increase in size when the heart beats and it will decrease in size during what's called diastole. And depending on the quality and the type of software in the CAT scanner when you go and get that done and the analysis, there can be a variation in your size by anywhere from 1 to 3 millimeters. Okay. So I don't even consider 1 to 3 millimeters a change unless I see the change twice on 2 successive CAT scans. So how do I prove that? If you come to me and you got a CAT scan and it says you're 4.5 centimeters, and then I get another one and it says you're 4.8, well, I'm going to say we're going to get another one in short order, meaning in 3 or 6 months, and I'm going to use that to create a line. One of those points is not going to land on that line, and whichever doesn't land on that line basically gets, taken with a grain of salt. And that's what you need to know. Don't let the numbers that you get on the report, because you're going to look on your patient portal and see that report before you see your surgeon, and that may really create a lot of anxiety. It's really important for you to go to the surgeon that you're working with and wait to get the analysis of the CAT scan at the time. It really will help you to decrease your anxiety if you just take a deep breath and wait for that conversation.
As a survivor myself, I feel like you're talking directly to me. That used to be me. Look, I'm coming up on 7 years. So in the beginning, I think it's very normal. I've made the phone call to fellow board members in the parking lot with the results, because I will be there when it opens. I used to be reading it, and it is with scanxiety, they call it. And as you know, my surgeon, he sat me down and he'll say to me, until I'm worried, which I'll never be worried, there's no reason for you to be worried. And it takes a lot of time to, not that I don't trust my doctors, but to have faith just for and in myself, which all goes into the mental health aspect that we will get to and talk about your survey. It took a long time to have faith in that because it wasn't caught to begin with. So it plays on your mind, and working with a good therapist has really helped me learn to just go in and have it. And I have to do what I can do for myself, which is follow the directions, take my medications, pay attention to what I need to, and let the doctor do what they do, which is read it and tell me what I need to do if there's any change. So I think for a lot of new people, the sooner they can adapt what you just said and not worry about all the complicated calculations and, should I breathe now or not breathe? That's not their job. Their job is just to always be hydrated, go in, try to be as calm as you can, meditate, do whatever you need, get your test, and get out of there and go back to doing what you have planned for your day. So I appreciate you going through all of that. I don't even think I knew all of that goes into a scan, because I get MRAs and I sleep during them anyway. So that's a whole other story. All right. We just addressed aneurysms, and they can have them for many reasons. You can, obviously, we know a lot of this is, if not all, hereditary. Bicuspid valve, that can create aneurysms. Yes, for all of our valve people watching. Okay. So let's go on we've hit the fork in the road. Let's say you have an aneurysm, you have an aneurysm. At what point do surgeons typically want to repair that aneurysm? And I'm sure there's equal amount of thought that goes into that as you just shared before.
So we have developed a fairly simple algorithm which allows us to apply the rules across the board and allows us a certain amount of comfort in that, as we've chosen these numbers, which I'll give you in a second, and we've repeatedly looked at patients over time who have been followed for years, and we use these numbers, and I myself graduate patients every year. It's almost a very it's a very interesting thing to sit in an office with an 88-year-old person and tell them they graduate and that they don't have to come back, and they say, I'll see you next year, because there's a certain comfort that they have, knowing that somebody is keeping an eye on their aorta, even if they know we're not going to operate on it because of comorbid conditions and because of risks. But I do graduate people every year. And as a whole, I think that we operate on roughly 50% of the patients that we follow in our aortic center. Um, and that means in their lifetime. I don't mean in a year, I mean in their lifetime. So if you're identified as having an aneurysm, you go into one of two places. You either go into a high risk pool or you go into the standard risk pool. The standard risk pool, as of now, in the chest, is that if you have a ascending aortic aneurysm of 5.5 centimeters, we will offer you an operation based on the fact that the risk of surgery and the risk of death and stroke from that operation is less than the risk of rupture or dissection at 1 year. Now, how would we come up with the most arbitrary concept of that? Well, the answer is a very simple thing, and that is that we decided that it's not appropriate to analyze people's aortas more often than once a year unless there are specific concerns. We know that radiating people over and over, giving people contrast over and over, in some cases that's necessary, other cases it's not. But all of these CAT scans add up, and we don't want to create another problem for patients, especially when they're young and they come to us.
Mm-hmm.
So we've decided that the 1 year interval is the standard follow-up interval unless problems arise. If that risk is okay to accept, because there's no one in this earth who has a zero risk for anything, happening. So we know that there's always some risk. And so whatever that risk is, it has to be less than the risk of surgery for us to be comfortable waiting. So at 5.5 centimeters, the risk of surgery and the risk of waiting start to shift. So for the average person, the risk of dying from the operation average is about 3 to 5%. And the risk of dying without an operation, if your aorta is 5.5 centimeters or greater, is about 10 to 15%. And I'm using much larger spans in order for you to appreciate that there's a lot of other issues. But 3 to 5% versus 10 to 15 is pretty easy to figure out. So we offer you surgery. Now, that's in the standard risk pool. In the high risk pool, if you have a family member with a aortic dissection, aortic aneurysm that's been operated on, with a bleeding cerebral aneurysm, unexplained sudden death, or known connective tissue disorder, either in yourself or a first degree relative, these are incredibly important things that would lead us to want to operate on you sooner. And so we would offer surgery at a half a centimeter earlier in the ascending aorta, 5 centimeters.
Okay.
Those are the two categories. Now, there are caveats to these both, but those are the two major meat and potatoes. Now, quickly, if it's in the arch, which is a higher risk operation, we sometimes will increase the size in the descending aorta, where we can put in an endovascular stent graft and just place it in the aorta. We sometimes we will always choose to do the surgery at a smaller size because the surgery is safer. So it's always a comparison of the risk of the surgery versus the risk of a complication without the surgery.
Okay, that makes a lot of sense, actually. I've read a lot of things that community members say, and that just summed it up. So if I have any reason to really sell this video after we're done, it is going to be really that information, because I think the individuals in the watch and wait crowd struggle with this so much. And, I guess I'm one of them now, but when you've already had a dissection, watch and wait is not necessarily so tragic, because you're being watched. So I feel very fortunate and very lucky that the chances of something going awry are significantly lower. So let's jump right into dissection. Let's talk about a dissection. And I've heard people, I think they're getting confused with dissection versus I survived a rupture. So how do you differentiate between the two?
So in patients who have an aortic dissection, you basically have either a type A dissection, where the tear in the wall of the aorta occurs, but it does not rupture out of the tube. It goes into the wall and it will propagate through the aorta. And sometimes it stops in the ascending, sometimes it stops in the arch, sometimes it will go all the way down into the descending and into the belly, and sometimes it goes into your feet. The idea that the A stands for a primary or most proximal tear site in the ascending, ascending. Shifting over to the type B, the type B, the ascending is spared and it starts in the descending. Descending.
This is what you teach your patients. I love it so much. Okay.
Every day.
I love it.
B, descending. A, ascending.
Okay.
Okay. Going back to our model, A, ascending, B, descending. Okay. So that is a dissection in a nutshell. We can talk a lot about what that means, but that's a dissection. A rupture, everybody who's ever had anything in their life that has poked a hole in it, we know what a rupture means. If you have a dissection, the outer layer of the aorta is being charged with holding the body's blood pressure in place, and therefore you could see how there's a possibility of that outer layer tearing and it will rupture out. When that occurs, it is usually a small leak that starts and you feel it and you come to medical attention. The ones that just explode, that's on TV. Okay, people, that's TV. That's not the way the body works. The body has a lot of secondary and tertiary backup systems in order to keep these things from happening. Back during, the Stone Ages, patients who would, the cavemen that would walk and just would spontaneously explode, they didn't usually go on to have babies. And so those genes of spontaneous explosion or limbs falling off and death and all that stuff, that was like kind of Darwinian, moved out of so we have a lot of really great backup systems. These backup systems protect us. The number one best backup system we have is pain, because it alerts you that something's wrong. And those bring you to medical attention, or at least gets you back to the cave, as in the caveman analysis. Okay. Now, there's an aneurysm, which is an enlargement. And there's a dissection or a tear. And then there is a hole in the tube where it's leaking out of the system. That's a rupture. Okay. And the reason we talk about them all together is that they're interrelated, but they are not the same.
Gotcha. Okay. Talking about ways to fix these. Everybody just assumes when you have and before I get to that, do people ever have type A and type B? I think that now all of a sudden light bulb went off watching you looking at this visual. It really is truly either or, because you can have a type A that starts in the ascending and, like you said, goes all the way down to your iliac. That's still type A. It's not A and B. It encompasses the whole thing.
So the difficulty for patients is that they think that they're different, but in reality, the aorta is one organ. It starts at your heart and it goes into your legs, and all the side branches are involved. One of the things that myself and Dr. Rob Ree, who's my co-director, one of the things that we are so focused on in our aortic center is getting patients and the general public that we work with to appreciate that this is one system and that nothing is isolated. And that if you have two surgeons who subspecialize in this work and overlap in their area of surgery, such that you can have good conversations, then you'll start to be able to talk about it like we do. Going back to the example of the cardiologist who called the patient over to see me, I had the patient sit down, I looked at the patient's CAT scan, and lo and behold, the patient has an aneurysm in their ascending aorta and an aneurysm in their abdominal aorta, two separate areas that are enlarged outside of the normal range, but it's still the aorta,
Right.
and they still need to see someone, and we still need to have conversations about how to handle it and which size and what goes first and what goes second and things like this. Understanding that it's a continuum is critical for managing these issues. Now, in terms of dissection, a type A dissection can encompass what people routinely call a type B, which is in the descending.
Mm-hmm.
But once the type A is fixed, what you're left with is it's something that we refer to as a residual type B dissection. The term, which is just a term that we use in our business, is a residual tear that exists predominantly in the distal arch and the descending aorta that is still there after repairing of the type A dissection. And it is usually still there. The overwhelming majority of the cases, it's still there. And when people need repeat operations, that's the reason. It's because that tear is still there. So the purpose of the operation for a type A dissection is to solve the problem of the issues between the heart and the blood vessels to the brain. The
Okay.
issue with a type B dissection is actually far more complex, and we can talk about that briefly if possible.
So because you'll have a lot of people who have had type A residual B or B, and they don't understand why they come out and they still have a tear. Like who lives with just being handled with medicine? And the only answer that we ever give is because it's far more complicated to try to fix this on the table, and the risks outweigh, the benefit at that point. So is there an easy way just to explain why is this? Why do you let people come off the table?
Very, very simple. The old surgeons who really lived in a world where they intervened but were unsuccessful in 20 to 50% of the cases, they didn't know what to do. So they did whatever they thought was best. And they tried all sorts of things to fix aortic dissections. And one of the most dramatic things that they tried was to go into the chest and belly at the time of a type A dissection and fix the aorta and make it look perfect. And some of the more talented surgeons made it look well.
Mm-hmm.
These endeavors led to the expression, the surgery was a success, but the patient died. These conversations and these now sort of not funny jokes was a direct result of the surgeon's belief that every patient had to come out perfectly from the operating room. Otherwise, they were going to just die anyway.
Mm-hmm.
As the evolution of cardiac and aortic surgery has gone through the phases from the 1960s, 70s, and now we're 2020s, we realize that what we actually need to do is solve things in order, in series, not in parallel, and do things to allow the body to accommodate for the changes that occur as you operate on them and allow the body time to heal. These have led to a series of operations that we do on patients who have both aneurysms sometimes, and definitely with patients with aortic dissections, because we know it's safer to fix the problem that brings the patient to you and then address the subsequent problems, which we are well aware of.
Mm-hmm.
Patient recovers from that initial insult.
I have to tell you, I am just learning. This is so good. Thank you so much. You you just said something, evolution, and it reminded me of a conversation that we've had before where you have defined all of these community members that are part of Aortic Bridge, Aortic Hope, as the new generation, the first generation. That was what you said. So really the first generation of individuals who probably will live a lot longer than the stats that we find on, look up a doctor that says you might die in the first 5-10 years, which debilitates new survivors until they find the community members.
Yes.
So what does that mean? Explain to people what it means that are watching or listening of us being the new generation.
So I use that term and hoped you would never say it out loud in front of other people.
but it's so
but
good.
it's very, very specific, and I'm going to show you some toys. So I showed you this endovascular stent graft. These stent grafts were approved in 1998 and 99 for use in the belly for abdominal aortic aneurysms. They were then approved by the FDA in March of 2005 for use in the chest. I was certified in December of 2005. And that operation was this. So this is the other side.
Mm-hmm.
Here's this. Turn it around. We bridge from normal aorta to normal aorta, excluding this portion, which will then scar in and squeeze down over time around the stent graft. And this area will no longer be at risk for rupture or dissection if the body allows it to stay and remodels around it. So what we are taking advantage of, and I work with a guy who's very progressive in his thinking, and I also believe in some of these more modern techniques in order to use the technology that we have available to us today to improve the outcomes from patients with aortic dissections, both type A and type B and residual type Bs, by using all of the available techniques to limit the events that usually occur and that did occur and that still do occur when somebody gets the old repair without any follow-up, without any conversation with the patient and their family about recurrence of disease, without any discussion about thinking about the aorta and thinking about the family and that it runs in families, any of these things. And the patients show up with a scar on their chest, coughing up blood, with a 10-centimeter aneurysm that's in the residual type B that is now ruptured into their lung. And they're looking at me and they're saying, "Hey, doc, can you fix me?" And I say, "I could if you came to me today with the original problem, but now we're 8 years later and you're rupturing into your chest, and I can't fix this disaster easily, although I will try."
Mm-hmm.
But the problem is that the new generation, as I described to you, are the people like yourself who are being followed by people like me and by Dr. Taylor and by all the people around the country who I know very, very well. We all work together. And I was just on the phone with one of my friends and colleagues named Dr. Eric Lair, who's out at Swedish Hospital in Seattle. And we were having a conversation about the interesting reality of our progress into being the senior surgeons now and how we discuss and approach our interest in finding out the last few answers to the questions that we've had over the last 10 years. But we're using this technology in these new ways to fix some of these old problems, because when we saw the complications from these old problems, they were so disastrous for us and they were so disastrous for the patient and families that we've been working very hard over the last 10 years to come up with ways of at least trying to address them. And
Mm-hmm.
the next step is for us to try to isolate these different techniques and decide which is the best of them to approach some of them. And we haven't quite figured that out, but
Mm-hmm.
we're getting to the point where we're going to soon isolate a handful of techniques and then try to apply them in a way that will help give us better answers moving forward.
And I think also one of the things we talked about is, which came up in Think Aorta, is that the realization that aortic disease was not limited to just people with known connective tissue disorders or known syndromes like Marfan, Loeys-Dietz, and what have you, that they were the ones that were getting the golden treatment if they walk back in subsequently to a hospital, to an ER. And somebody else like me who may not have had something, if I went in, prior to my dissection, maybe wasn't getting that CT scan right away. Maybe I was being told, "Oh, you wrenched your back," or "You have something GI." So we are now of that new generation of people that you're realizing these people need to be seen. Hence, they need to think about the aorta and the follow-up, which is so key because the follow-up wasn't always there.
So this brings up the two topics that are the most painful to me. And I'll give you the two examples that I've heard countless times. Whoops, sorry. Countless times. Don't bang on the table when there's a camera. I've heard countless times. And one of them is somebody comes in who is not tall and thin as many Marfan's patients are. They're short, and maybe they're even short and fat, and they say they have chest pain, and maybe they even smoke. And the patient could say to the practitioner in the emergency department, oh, yeah, my father died suddenly at age 55, and my brother died suddenly at age 47. And that person will never be thought of by the older generation as possibly even having a dissection because they don't fit the bill of what we all learned in medical school. And I had a medical student just yesterday answer the question, and I had to just stop in my tracks. I said, you are carrying on prejudice that will lead to the death of a human being. You need to understand that the overwhelming majority of patients with aneurysms, ruptures, and dissections do not have a known connective tissue disorder syndrome, but I believe very strongly that all of them will have a genetic predisposition, some of which we don't even know yet. So that's number one, huge frustration. The number two frustration, Karen, and we've talked about this, and I had a horrible example of this just last week, where a patient came in with an aortic dissection, and I operated on that patient. And in the intensive care unit, I was talking to the wife about how this runs in families, and it's critical for the brothers to get evaluated, and the son and the family, and we have to figure it out. I said, because if this happens to one person in the family, it's a disaster. If it happens to two people in the family, it's an overwhelming preventable tragedy in a large percentage of the cases. And what happened? That patient's brother showed up and told the wife, didn't she know that their oldest brother died from a dissection 5 years earlier, but the patient knew he had to get checked out, decided not to do it, decided not to tell his wife, which we know is a risk factor for probably dying if you don't tell your wife something.
Right.
For two different reasons.
Yeah, yeah.
And he winds up getting a dissection and getting very sick. And he was never followed and never scanned. These two things, one, the fact that people have prejudice against what people look like, so they don't think aorta. And number two, people even know that it runs in families, but they don't know that it's genetic. Those two things, Karen, if we can take these events and have those two things be like screamed from the rooftops, we would save so many lives every year.
Well, and that's our goal. That's what we're doing. All of these organizations, that's what we're here to do on the proactive side for sure. I want to check in and see if we have any questions or comments. Hey, Greg. Hey, Deb. Hey, Tim. Yes, I had to write down all three names as they were being told to me because I have such bad memory. But hi, do you have any questions? Okay, somebody has to have a question in the back of their brain. Somebody has to have something that they're experiencing that they would like to take advantage of this moment and ask a question. And while we're waiting, let me ask you to talk about your study. This study that is going on at your hospital is so amazing because one of the major complaints, and we've discussed this before, and this is partly why Aortic Hope came to be, is if I had had somebody come into my hospital room or definitely my first follow-up appointment that was like me, that was standing, walking, talking, my recovery would have gone so much smoother. But to have doctors and nurses who have not had their chest cut open, who have not had this experience, tell me, go live your life. It's gonna be fine. It's so unnerving. And I was not prepared for the overwhelming emotions that I had, the crying, the guilt, the having to figure out my new normal, which everybody hates that terminology. There's so much, especially with a dissection, so much PTSD, flashbacks, triggers. It was a whole other syndrome and illness I was experiencing while trying to recover from having my chest seared open. It's not discussed. It's not handled enough nationwide, for sure. Globally, definitely not enough. this survey is really addressing some of that. If you want to tell everybody, because we've posted it in many different places, this will give you an idea on what you're helping to participate in.
So I'm going to bring you way back to, unfortunately, to the wars of our country. And I'm not talking about political, I'm talking about young men mostly, and now young men and women going off and being put in an unbelievable situation, being asked to do unbelievable things, and seeing things that no human being should ever see. And they come back to their life if they're lucky, and they're told, live your life and be normal. In the past, and I have some very good friends and colleagues that were military people in various countries. In the past, if you showed signs of dysfunction, if you tried to kill yourself, if your relationship with your spouse, family, children, and everything fell apart, if you started beating on your friends, then somebody said, oh, something may be wrong. Maybe you should be evaluated. What we now know is that because because soldiers are going into these abnormal situations, that everything is not normal. And when they come back, they have a degree of traumatic events that result in a degree of post-traumatic stress. And some of them get the diagnosis of post-traumatic stress disorder, underlying disorder. Disorder means you can't get your life together because of the stress that occurred and the trauma and the post-traumatic stress that occurred. But that is only a subgroup of all the people that went through this incredibly complicated event. So now soldiers are debriefed, soldiers are told all these things are abnormal, and the 100,000 plus horrible events of suicide in the military are being addressed very forward thinking with some wonderful, wonderful groups crossing boundaries of culture, crossing boundaries of all kinds of different countries and what have you. Now, let's get rid of that. That's where all the research was done. And let's go to patients walking down the street, and you basically get hit by a car, struck by lightning, smashed over the head, shot through the chest. However you want to describe it, it is exactly the same massive stress. You come to the hospital, somebody like me, if you've never met before, who may be a little too old, a little too young, a little too funny, a little too tall, tells you they're going to bring you to the operating room and you might die, but they're going to do their best. And do you trust them or not? And you don't have a choice because you need to go now because you might die just even thinking about this. And then you come out of the surgery with some degree of, confusion about what just happened, a significant amount of pain. It is unbelievable what you all go through. And if the people who get the surgery, like Karen, and the people that have to sit every day and wonder if it's going to happen to them versus the people who get to have elective surgery, all these three groups, or how about the people whose family member has this event and they're too scared to go get the CAT scan because they don't want to find out because then they don't want to deal with the stress of knowing. Four groups of people: family history, aneurysm, waiting, aneurysm, surgery, dissection. Okay. We know, and the psychiatrist that I work with every single day, named Dr. Melanie Schwartz, who sees every single one of my patients. I don't want to hear about it if you don't want to talk to a psychiatrist. I don't want to talk to you either. Tough. You see them like you see me. They need to address your mental health to help you get through this crazy event. We have decided that we need to gauge what's actually going on because it's never been studied and it's never been asked what happens to patients in these four categories. Family history, I don't know. Diagnosed with an aortic aneurysm, no surgery yet, but waiting and scared. Surgery, but elective surgery, or an emergency operation or an emergency event. These four groups. We are asking the questions to scale how much stress, and are you suffering from that stress in a disorderly way that's affecting your lives? And we've lumped it together with this crazy pandemic issue. And we've also lumped it together with this overwhelming discussion about whether you yourself should be vaccinated. How much at risk are you for getting sick because of this diagnosis? How much worse would it be? And all these types of things. We've put it together in a package to say, if you are having one of these aortic conditions in 2020, 2021, we want to know what we're dealing with. And we're going to follow you and your group of patients every year for probably the next 10 or 20 years and see if all of these are things that Aortic Hope, Aortic Bridge, and Think Aorta are doing to change the attitudes of people in this country is going to positively deflect the stress towards the baseline. That's my hope.
That would be amazing. I mean, that's the reason that this was started, honestly, was there was something missing. It's great to see quotes that you're trying to subscribe to, that you're trying to buy into. It's scary to read people's experiences and wondering, is that going to happen to me, or feeling guilty that it didn't happen to you? Do I not belong in this group? So what we're trying to do is, and I love this, your survey will show if we're being effective in providing people what they need wherever they are in the course of their recovery and the management of their recovery. So I will get that study information. We will get that posted so that anybody else who sees this and hasn't had a chance to participate will do so. And the last thing I want to talk to you about, and this is, I'm not trying to, we actually have a question before I ask my last question. We have questions. So why does a dissection present in so many seemingly random ways? From Kim.
So the issue of a dissection affecting all the blood vessels of the body is exactly the potential for it to look like a heart attack, change in blood flow to the heart, a stroke with change in blood flow to the brain, a stroke with weakness or change in blood flow to one arm or the other arm. It can look like an abdominal event, like a ruptured gallbladder or an appendix if you have blood flow to the belly. It can look like all kinds of crazy different things. And the problem for practitioners, and we've talked about this before, if you take all of the emergency physicians around the country, this is our country, they will see an aortic dissection every 2 to 4 years individually. But when I have a dissection in the emergency department, every person who's there comes and looks at the patients to get a sense of what's going on. And I do a really quick teaching thing about what to do and checking blood pressures in all 4 extremities and doing a good neuro assessment and checking an echo on the heart and then getting them quickly to CAT scan and not being by the first thing that you see when you see all these other things that don't make sense.
Mm-hmm.
The expression of is if you're a hammer, everything looks like a nail is exactly the reason that patients will die when they present with an aortic dissection. Because if you are focused on every chest pain being a heart attack, or everybody who's a little confused being dementia, or in one arm or one leg being a stroke, you're going to miss this diagnosis. Not a lot, but you're going to miss it. And if you miss it, and if you delay it, we know, especially for a type A dissection, the risks of death are very, very, very high. And it's such a hard job they have. But our job is to let them say, could this be a dissection? A, B, and C, check it out, get a CAT scan. No, it's not a dissection. Move along. Fine. That's easy.
Right. Eliminate the most threatening. You need to take that.
I apologize. I do indeed. Pardon me.
Saving the world. Do we have any other questions? Well, I do know the answer to that question. And Joan, so the question is there a relationship?
Karen, I can't.
Yes.
Hey, it's Ben Youdelman. Hold on, please. Karen, I literally have one of these calls and I'm going to have to go.
Thank you so much for your time. I will finish trying to answer this person's question. We will catch up with you. Okay, so as you see, a surgeon's job is never done. There is a relationship between ankylosing spondylitis and aortic dissection. If you want me to give you the specifics on that relationship, I cannot. However, if you shoot us a message at info@aortichope.org, I can put you in contact with another individual in the community who does know. She's actually spent a lot of time trying to share and educate and make individuals in the AS community more aware of the propensity and chances for having an aortic dissection and why it's so important to be followed by a cardiologist. I think this also goes for any type of disease that creates inflammation within the body. That would be lupus, rheumatoid arthritis, Crohn's, colitis. It would make sense to bring that up to your practitioner and let them make the decision on when to give a baseline scan. But to answer your question directly, yes, there is a relationship, and we'd be more than happy to connect you with another person in the community. Do we have any other questions that I can try to answer? Oh, okay. All right. So no other question right now. One of the things I was hoping that Dr. Youdelman would be able to close us out on would be the issues for people in our community in contracting COVID. I don't bring this up to cause any type of controversy on vaccine or no vaccine or what have you, because there is scientific evidence to back up the fact that if an individual in our community does contract COVID, we are putting ourselves at risk. However, this also holds true for if you develop the flu or chickenpox or anything of that nature, and you do put yourself at a little bit higher risk for having a complication. You're not at higher risk for contracting something, but the reason is your heart rate does work faster and harder to eliminate the illness that's in your body and the virus in your body. And of course, we know a higher heart rate, and they've been clocked at 120, 130 resting, and higher blood pressure does not serve us well. So this is one of the things that you should take back and have a conversation with your doctor to determine what is best for you having aortic disease as far as having a vaccine. It's a real serious conversation. It is not politically motivated. It is life or death, and we have diseases. We have a disease that greatly could be impacted by having this virus. So that was where I was going to end it with Dr. Youdelman. We will get the study link up to you. It is on our Facebook page right now. However, we will be posting an updated link on our website shortly. And I'm going to say hi real quick to Molly for joining us. I'm sorry that we have that question repeated. Is there interest in contacting every survivor that's had an aortic dissection? I don't know. I think that would be probably difficult because as we've found being on Facebook with 3,400 plus followers, there is overlap amongst the pages. This is just of those individuals that are on Facebook. There's a huge community of individuals that are not, that we know are out there, and that's who we're trying to tap into. As far as the best way to connect with other survivors, that would be through events that happen within the community, such as Rock from the Heart is having an event. There's different events that happen. Aortic Bridge is having a walk coming up soon. But as far as practitioners trying to reach out, I'm not sure that they're going to do the reaching. We have to reach amongst ourselves in the community. Hope I answered that. I was thinking about that question. Okay, so that is it for tonight. Again, it is Aortic Dissection Awareness Month, and we think of it as being a month because there's way too much exciting information to share with you. We would never be able to handle it all and cover it all in just one day or 1 week. So we hope that you join us for all of our live events. We have upcoming a live event with Dr. Stacy Fisher, who's a cardiologist. She'll be taking your calls. We do have an Ask a Doctor event with Dr. Siddharth Prakash on our Facebook page. We will also be having a live event with the attorneys Doherty, Cella, and Keene, who specialize in navigating the disability process. This is a very popular live event, so we're very happy we could have them join us again. We're going to be doing, hopefully, a live cardiac yoga event. That's our first time. And we're having our first bingo event, which will be in a closed town hall meeting with lots of really great prizes. This is free. It is our gift to you to take your mind off of disease for a little while. And as you'll see, we have some great contests happening as well on our Facebook page. So thank you all so much for our first night for Aortic Disease Awareness Month. And thank you to Dr. Youdelman for giving us this time and joining us. And we will see you all soon. Thank you again.